Hello, everyone. Welcome to Journal Club. It's great to see you all. My name is Ian Hageman, joining you from Washington University in St. Louis. I'm one of the moderators. My co-moderator is Dr. Zara Ordulu from Brigham and Women's Hospital. Thank you for joining from wherever you are in the world for our October Journal Club. Our topic is GYN cytopathology. I'd like to remind you of recent and upcoming events from ISGyP Live. October did not have a webinar or a slide seminar, but we do have an upcoming podcast that will drop on October 23rd on the subject of Dicer-1 tumors and ovarian sex cord stromal tumors with speaker Chris Ann Schultz from the United States. This can be accessed on SoundCloud. We will have an interesting case presentation moderated by Drs. Pinto and Turashvili on the subject of ovarian tumors, also October 23rd at noon Eastern Time. You can register at isgyp.ca. You can also access, for members, you can access the archive of other past ISGyP Live events. We recently had the ISGyP annual meeting, and the sessions, which consist of bite-sized chunks of gynecological pathology, will be posted on our education site. They're not yet posted as of today, but they will be, isgyp.ca. Journal Club is global. We would love to see you at either our Eastern or Western Hemisphere cycle of Journal Clubs. So we do this every month with a few occasional breaks for conferences or holidays, alternating between a time that is convenient for the Western Hemisphere and the Eastern Hemisphere. It can be a little bit confusing with the time zone differences, but our aim is to reach everyone at a time that is convenient for them. We have a cycle of topics that alternates between the Eastern and Western Hemisphere. We're near the end of our cycle for 2024, and we'll start over in 2025 with another set of topics and dates. So we will be sure to notify you about those. We'd love to have presenters. This enterprise only works if we have junior pathologists, trainees, new in practice pathologists who are willing to present. So if you are a trainee or a new in practice pathologist and are interested in presenting in Journal Club, please send us a note. If you're interested in presenting an interesting case, please send us a note. We would be happy to put you on the schedule. We do have availability, and we provide mentoring to help you improve your presentation before you deliver it to this friendly audience. So it should be a good experience. If you're a training director, faculty member, fellowship director, and you know of a young trainee or new in practice pathologist who would be interested in presenting, send us a note and tell us their name, and we'll be happy to put them on the schedule. This month we'll be covering GYN cytopathology. We have three esteemed presenters. Dr. Padmini A Manrai is an assistant professor at Brown University Medical School. Dr. Mahjabin is a second-year resident at the University of Florida in Gainesville. And Dr. Hafsa Nebash is a fourth-year resident and chief resident at the University of Kentucky. We're very grateful to them for presenting these papers that you can see the titles and data here. This presentation will be archived and available on YouTube for you later and on our ISGyP education site so that you can come back and dig out the citations, which are also in the email invitation that you would have gotten. We like to review briefly the purpose of Journal Club. We aim to disseminate knowledge and emerging ideas about gynecological pathology and to center our trainees and young members of ISGyP as presenters and moderators in order to provide a pipeline for future engagement and leadership. The format of Journal Club is very similar to other Journal Clubs you may have attended. We focus on whether the article presents appropriate background, methods, results, interpretation of those results, and then we talk about the strengths and potential weaknesses of the articles that we're discussing. We'll have our three presenters in the following order, and then we'll save all questions for the end so that we can ensure enough time for everyone. In this webinar format, there's a question and answer box that you can post questions into. You can also use the chat function to exchange with one another and let us know where you're calling from in the world. And I see a couple of chats already. Any Q&As that you might post in the question box, we'll triage and we'll try to address at the end if there's time. So with that, I'll end my presentation and I'll invite Dr. Manrai to share her screen and start her presentation.
Thank you. Okay. Well, thank you so much for this opportunity. My background is in gynecologic pathology as well as cytopathology, so particular interest in this topic. The paper I'll be presenting is on the effect of HPV self-collection kits on cervical cancer screening uptake, specifically amongst underscreened women from low-income backgrounds. And this is part of the My Body, My Test trial that was done out of North Carolina. And I think this is it's a particularly relevant topic given the recent FDA approval of self-collection for primary HPV screening. This was back in May, and so we're going to start to see the spillover effect of this in the coming year. And so I think informing ourselves of what is this and what tests are used and how we can move forward. So I wanted to, this is from one of the CAP publications that came out. And I think just to give us a perspective, because there's so many different changes to cervical cancer screening that are happening now. And I know from, as a pathologist, when I first heard about the self-collection and then the shift to primary screening, yeah, of course, my initial reaction was like, wait, let's see, what's the data behind this? But I think this is a great quote that, you know, if we were to design a whole new screening test today that had greater than 90%, of course, we would pick that over something that had 50% sensitivity. Now, again, that's for PAP alone, co-test as comparable to HPV primary screening. But the idea is that we want to capture as many women as possible. That's the idea behind a screening test. And so something with more sensitivity is one way to do that. But the other way is also to try to reach as many women as possible. And specifically targeting low-income women that might not have access otherwise. And that was the goal of this study in general. So some background, there is this shift in guidelines to primary HPV screening with reflex to cytology as opposed to the other way. The data per CDC and many studies have been done over the past decade show a similar sensitivity to self-collected samples compared to provider-collected samples. Now, eligibility for HPV testing by self-collection is women need to, this is the current FDA approval, they shouldn't have insurance or they should live in a medically underserved area. There's a lack of time, transportation, childcare for their appointment, or performing a pelvic exam is unacceptable in situations of trauma or otherwise difficulty during a pelvic exam. And importantly, there are only 2 approved tests by the FDA in the United States for self-collection methods for primary HPV testing. And these are the Roche as well as the BD Unclarity systems. And there are lots of different methods. So each Roche and BD have their own swabs, and then there are a whole host of other brushes and methods and devices that are coming out, but none of them are actually approved yet by the FDA. The only one within the US is the Teal wand, which is breakthrough designation. So they're trying to expedite approval of that. But right now it's just Roche and BD. So this study, the My Body, My Test, was a phase 3 open label 2-arm randomized control trial. It was in North Carolina. It served 22 counties, and they looked at 21 different clinics within those counties. Their patient cohort was women that were aged 25 to 64, not pregnant, and had an intact cervix, so no hysterectomy history otherwise. And they had to be, their goal was their income of 250% or less of the US federal poverty level, and uninsured patients or enrolled in Medicaid, Medicare. And the additional criteria is that they shouldn't have had a PAP test in the past 4 years or an HPV test in the past 6 years, because then they would be considered underscreened if they meet this criteria. And these were by self-reported, since we don't have a nationwide or statewide registry for HPV. They used a variety of methods for engaging patients and recruiting women to this study. So they used printed ads, radio ads, online postings, lots of community outreach. And eligibility for the trial was assessed via telephone questionnaires that were administered by the staff, and consent and HIPAA forms were sent via mail. So it was a pretty extensive outreach to the community for this. As far as randomization and masking, women were assigned 2 to 1. The intervention group was women who they received a mailed HPV self-collection kit, as well as assistance in scheduling appointments for in-clinic cervical cancer screening. That was the intervention group. And then the control group was women who only received scheduling assistance. Then they additionally stratified these women by their county to reduce any imbalance that might have been there amongst the county distributions. So the method that they used was for self-collection, something called VibaBrush. And then the sample media, the transport media that they used was Aptima sample transport media. So women would self-collect via the VibaBrush, and they would eject the brush into the sample transport media. Then they would mail these kits back to UNC, where they were de-identified and processed, and sent to LabCorp for testing, for high-risk HPV testing. And they specifically, this Aptima assay uses high-risk HPV-6, E6 and E7 mRNA of the 14 high-risk HPV genotypes known to be most prevalent for cervical cancer. The intervention group participants were informed of their high-risk HPV results by telephone call, and then asked to come back in or to come into clinic for a provider collected sample. Women who didn't return self-collected samples were within 3 weeks were first sent a letter, and then after another 2 weeks, a reminder phone call. And all participants, regardless of whether they were in the intervention group or in the control group, received assistance for scheduling their appointments. Up to 3 phone call attempts were made to provide scheduling assistance. And the co-testing that was performed within the control group, as well as women who needed to come back in if they tested by self-collection positive, they had to have a co-test in the office. And this was used or done by the thin prep liquid-based cytology with preserved site solution for the brush samples. So as far as their study, overall, through screening with all of the eligibility exclusion criteria, they ended up with 697 women that were eligible to participate in this study. And of those, they randomized them 2 to 1. And then further had to do some more screening out, mostly because they weren't able to confirm the status of these women's HPV or PAP testing history. So everything it was self-reported, but then they needed to confirm it based on medical records or in some way have that second level check. So in total, they ended up with 438 women in the intervention group and 227 in the control group. And the majority of the women in this study were around 40 years old and reported race of Black, non-Latino, or non-Hispanic. They were unmarried and unemployed. And what they found in this study was that the uptake of cervical cancer screening was higher in the intervention group than the control group. This was done by intention to treat, per protocol, and complete case analysis. But they didn't see any difference within subgroups by age, race, ethnicity, and education. And there also was not a different effect based on income of their women in the study. And so this is, again, showing that there was an effect noticed in all 3 different methods for analysis. So something that's pretty commendable about this, they had 78% of women return the self-collection kit. of the 329 participants with a valid self-collection result, 16% of them were high-risk HPV positive. So this is a bit higher. The nationwide prevalence is around 15%, so it's comparable. And then if we look at the overall intention to treat, because the goal of it wasn't just measuring whether or not the kit was received, it was, did they follow through with the results of that? And so from the patients who were in the intervention group, returned the kit, and were found to be high risk positive, they then had to come in for in-clinic testing with co-testing. And of those, 5 were referred for colposcopy based on their PAP, abnormal PAP results. And of those 5, 3 of them did actually were required to need treatment, and 2 of them followed up with that. And in the control group, of the ones that were co-test positive and needed further follow-up, there were 3 that were referred, and only 2, or there were 3 that were referred and none actually went and had their colposcopy. So it's a very, very small sample, but the idea is that this extra step led to more women actually getting treated that would need to be treated. So in terms of looking at just the sensitivity analysis and where we define what was a successful test, a lot of the studies in the past had just looked at whether or not the self-collection kit was returned, and counted that as success. We screened successfully. In this study, what I think is really interesting is that for them, it wasn't just that step of receiving the test back, but it was actually the follow-up, and that the patients did come back in and got the appropriate treatment. So I would say success rate is reported to be a little bit lower compared to other studies that are out there in the literature. But I think when they did an analysis where they just looked at the test kits received, and their success rate is comparable. So this shows that it has a downstream effect, I think, for this. There are a couple of other studies that look at this screening uptake, and specifically, this is one of the bigger ones at Kaiser Permanente, the home trial. And that looked at privately insured patients. I think that's the difference with this study, is that they are looking at uninsured patients. There was no elimination for language, so they included Spanish-speaking patients. And I think that is one of the advantages of this study. Some limitations, though, is that a lot of it is dependent on those who responded. So potentially these are more motivated women. There are a lot of, it also may not be reflective of the way we actually practice. It requires a lot of access to different facilities, and a lot of manpower on the people who conducted this trial. They also used the Aptima HPV assay, which is not, number one, it's not FDA approved for self-collection testing. It's more in the research area. And then there are reports that it might have a lower sensitivity. There might be a higher false negative rate with this testing. But overall, this study showed that mailed HPV self-collection kits with scheduling assistance will result in a greater uptake of cervical cancer screening, specifically amongst underscreened women and women from low-income backgrounds. And a meta-analysis of international HPV self-collection randomized controlled trials also shows this. So it is effective as a way to potentially reach a wider, broader net of women. They are doing some follow-up secondary outcome studies. And one of the things that comes from this is, how will this affect the way our current guidelines work? And so should women who test for HPV 16 or 18 be referred straight to colposcopy, skip the in-clinic screening? And would that potentially change the ASCCP guidelines and the workflow of the lab. And so that's really, as pathologists, that's what matters for us, I think, on our end, is how do we have to adjust the way we work? We're already doing switches to reflex to cytology, primary HPV to reflex to cytology, but this adds another dimension in that currently the FDA approval is that self-collection, if it's positive, women have to come in for an additional co-test by a provider. And so we would have to have a way of differentiating which samples came from self-collection versus physician collected, where we can immediately reflex to cytology for physician collected. And then this has downstream effects of the IT infrastructure and equipment, different test code potentially for billing. So lots of different things that we have to think about if this gets picked up more by our clinicians. And that's it. Thank you.
Wonderful. Thank you very much. We'll move on to Dr. Mahjabin. Please hold any questions or put them in the Q&A box. We'll be happy to field them. Mahjabin, if you'd like to share your screen and start your presentation.
Good afternoon, everyone. This is Mahjabin, the second-year pathology resident at University of Florida, Gainesville. Hopefully, everyone can see my shared screen, can hear me properly. So it's my pleasure to present here today, and the article that I'm going to present on is the diagnostic accuracy and the prognostic implication of pelvic and peritoneal fluid cytology specimens in ovarian clear cell carcinoma. This paper was published by Marshall et al. At the Journal of American Society of Cytopathology this year. So a little bit of background on the ovarian clear cell carcinoma, which is a rare subtype of all ovarian epithelial cancer, usually accounting for 5 to 10% here in the United States. For this rare subtype of ovarian carcinoma, the most significant prognostic factor is thought to be staging. And if we can get the neoplastic cells in abdominopelvic washing or in the cytology specimen, it usually upstage the patient. And according to the FIGO classification, it usually upstage to at least FIGO 1C3. And from the literature, we can say that the positive cytology, if we can compare the patient from with the negative cytology, the positive cytology confers a worse prognosis. Here are 3 patterns of the ovarian clear cell carcinoma, what we can see under microscope with H&E stain. So it could be papillary, could be solid, or could be tubular-cystic pattern. And if we can see our cytology specimen, maybe the ascites fluid here, and we can stain with the Pap stain. Usually the tumor cells are characteristic of the cluster which have the irregular large nuclei. Some have the prominent nucleoli, and we can see the focally vacuolated cytoplasm as well. And if we can see these characteristic tumor cells, obviously in the cytological fluid, we can say that maybe the specimen is positive for malignancy. Here is the FIGO staging for ovarian carcinoma. I'm not going to go over all the stages. I'm just trying to highlight the stage 1C3 that I mentioned before, that if we can find the malignant cells in the ascites or peritoneal washing, it will upstage the patient in 1C3. And after that, the higher stages like stage 2, 3, or 4, definitely the tumor will spread to the peritoneum or have the distant metastasis. So back to our study. The aim of our study is to analyze the diagnostic performance of the cytology specimens, such as pelvic or peritoneal washing or ascitic fluid in cases with pure ovarian clear cell carcinoma. Another aim was to determine the factors that could affect the detection rate and also to reassure that the patient prognosis depends on the positive fluid cytology. This study was a retrospective cohort study. For this study, they used the institutional laboratory information system to identify the cases for past 20 years. For this study, they used some specific inclusion and exclusion criteria. So the patients who were diagnosed with and treated for pure ovarian clear cell carcinoma at their institution was included in the study. However, the patient of this type of carcinoma as a part of mixed epithelial malignancy or choriocarcinoma were excluded from the study. Not only the patient had the pure ovarian clear cell carcinoma, but also if the patient had their corresponding pelvic wash or ascitic fluid cytology specimen at the time of their initial surgical resection were only included in the study. And the patient who had the neoadjuvant chemotherapy were excluded from the study. Also, the patient with recurrent disease or the patient by cytology, if was diagnosed as the suspicious for malignant cases, were excluded from the study as well. So based on those inclusion and exclusion criteria, they selected total 143 patients. And for those patients, the demographic of the patient, the type of the specimen, the volume of the fluid, those data were included. And the cases were sorted by the FIGO staging of their corresponding oophorectomy specimen or debulking specimen. However, the follow-up data were not available for all of the patients. 127 patients, their follow-up data were recorded in the study. And this is the conventional cytology method they used for their study, like after collection, the centrifugation, and they used the cell pellet for the cell block and used the deep quick and modified pap stain. And then the cytology results were per the conventional cytology reporting categories, and that were recorded for each stage. That was negative for malignancy or positive for malignancy or suspicious for malignancy or atypical cells. And for the statistical analysis, they use the standard hypothesis testing. They use the SAS 9.4. And to show the association between the fluid specimen type or the detection rate or the association between the survival rate according to the staging of the disease, they use the Fisher exact test, and the Kaplan-Meier survival probability curve were used and compared with the log rank test. So this is the results based on the data they were collected and analyzed. So what they found from this page, we can see that both of the figure 1 and 2 are showing the cytological detection rate according to the FIGO substaging and staging. So the figure 1 and the lower part, we can see that when it's stage 1A and 1B, they haven't seen any malignant cells in the cytology specimen. But when it comes to the stage 1C, it goes up to at least 40% the cytological detection rate. And as the staging are up rises, we can see that the corresponding the cytological detection rate are rising as well. So it's a reassuring the fact that as the disease are upstaging, the cytological detection rate is increasing as well. And from the figure 2, the cytological detection rate, it was compared according to the type of the specimen. So here we can see if when the patient has the stage 1C, the cytological detection rate was higher in case of ascitic fluid comparing with if the specimen type was any pelvic or peritoneal washing. However, when the stages are up, like if it's stage 2, 3, in that case, the detection rate according to like what type of specimen, if it's the pelvic washing or the ascitic fluid, it doesn't differ that much. And here is, we can see the graphical representation of the result where they compared the survival probability. The first one, the figure 3, it's just the stage 1, the survival probability, how it depends on that one. So we can see that when it's stage 1A and B, that's the negative cytology, their survival, the 5-year survival probability is almost 90%. But when the patient have the positive cytology, that is stage 1C, then the survival probability lowers down and it's now almost 70%. And in figure 4, the overall staging, that stage 1, 2, and 3, as the stages are rising, their survivability is decreasing as well. So on stage 1, it's close to 70%, but when it's come to the stage 3, it's lowering down to almost 20%. So this paper, they compared their study with previously published studies, like one of the studies, Brewer et al. According to their study, their cytological detection rate was 5%, and majority of the patient they used was the patient with the low stage disease. However, the current study, they used both higher and lower stage patients, and the 19% was the detection rate for stage 1 disease, and the overall detection rate was 38%. Another previous article was Hudgens et al. Their 5-year survival probability with positive cytology, that is stage 1C3, was 41%, and for stage 1N and 1B, which is negative cytology, was 86%. On the other hand, in this current study, their 5-year survival probability for stage 1C was 69%, and with the negative cytology, that is stage 1A to 1C2, was 89%. So if I can talk about the strength of this study, this is the largest cohort study of ovarian clear cell carcinoma cytology specimen in the literature. And also this study covered more high stage cases with the low stage cases of ovarian clear cell carcinoma if we compare with the prior study. But if we can talk about the areas of improvement or the things that we can keep in mind for the future research, we can say that this is a single institutional study. And if we can do the multi-institutional study and we can gather more data that could reflect all the cases from each FIGO subgroups, that will definitely make a study stronger. Also, I think additional larger studies are needed to further investigate the performance of the type of specimen among the FIGO 1C cases. And also, this study was a retrospective study, and I think the cases were selected for this study according to the clinical diagnosis from the pathological database. But if we can do a blinded re-review of the sample to do the to ensure the cytological diagnosis, I think that will make the study more accurate. And also, if we can correlate the patient's stage and also their different treatment options with the survival rate, I think that will give us a great prognostic scenario. So the take-home message, I think from the study, we can take that an accurate cytological detection is vital for this rare ovarian clear cell carcinoma, because we can see when the patient is diagnosed with positive cytology, that is stage 1C3, that will definitely differ the patient from other stage 1 substages. And when the patient have the positive fluid cytology, when we compare with the negative cytology, it's definitely the patient will have the worst prognosis. So that's all from me. Thank you so much for all your attention.
Wonderful. Thank you very much for the presentation. And let us pivot to Dr. Nibash's presentation if you'd like to share your screen.
Thank you, Dr. Hud. Right, okay. Okay, so today we'll be talking about Gynecologic Pathology Journal Club. My name is Hafsan Ebachi, PGY4 at the University of Kentucky. We'll be talking about an article that was published in Modern Pathology, Assessment of Efficacy and Accuracy of Cervical Cytology Screening with Artificial Intelligence Assistive System.
Hafsa,
Yes.
we are not seeing your screen shared.
Is it shared?
Not yet.
I'm sorry for the, there you go. Is it good now?
Perfect. Yes, it's perfect.
Thank you, sorry. Okay. Okay, so the article was published in Modern Pathology, Assessment of Efficacy and Accuracy of Cervical Cytology Screening with Artificial Intelligence Assistive System. So cervical screening has been effective in reducing cervical cancer morbidity and mortality. And this is due to the screening guideline implemented by the American Cancer Society and also the HPV co-testing and the HPV vaccination in adolescent population. We use for the reporting system in the pap smear, we use the Bethesda reporting system. Challenges that are faced during daily practice would be high volume of pap smears with limited professional and trained workload. So just like as a background, some of the AI technologies used in the cervical cancer screening are the AutoPap 300QC, ThinPrep imaging system, and Hologic Genius digital diagnostic system. These AI systems offer high concordance and sensitivity and also optimize triaging and reduce cytology workload. One of the limitations to the available automated system are the diagnosis of atypical squamous cell of undetermined significance, ASCIS, and also the glandular-based lesions. So this study was conducted by using the Rechan whole slide image to 2400 with the registered trademark AI site. The aim of the study was a novel AI system that was developed that would be capable of serving the needs of medical institutions by optimizing the slide reading efficiency and maintaining a baseline level of acceptability for sensitivity, specificity, and accuracy for the result. So those are the aim of the study. Method, the AI site system was developed using the Rechan, which is a fully automated cytology scanner with a 400 slide capacity. The cases used to develop the AI site system were 21,853 cervical thin prep PAP slides, 13,703 were negative for intraepithelial malignancy, NILM, 3,577 ASCIS, 3,198 ASCH, atypical squamous cells cannot exclude high grade, 247 atypical glandular cells, 440 were low grade squamous intraepithelial lesion L cells, and 688 were high grade H cells. So the AI system, the AI site system, excuse me, will also check the numbers of cells present on a slide during a slide scan. It will also report existence of air bubbles or artifacts, and it will report abnormal conditions. So what they did is they marked 20 most diagnostically relevant images, which are called object of interest, OOIs, machine diagnostics with a decision vector to diagnose NILM, ASCIS, atypical glandular cells, AGC, ASCH, and H cells. Malignancy score was implemented either 0 or 1, 0 for negative slide and 1 for positive slide using a threshold. So it would be a slide would be called negative if a malignancy score is less than the threshold, and it would be positive if the malignancy score is more than the threshold for suspicious or positive cases. AI site system also would successfully detect endocervical cells on the slide. So the case selection for the assessment of AI sites, does it work or not? So what are the cases used for this study? 32,451 cases were selected. 30.615 were negative cases and 1,836 cases with the findings of ASCIS and more severe abnormalities such as ASCH and HCL. 95.24% had HPV testing results. 12.94% had were HPV positive. All cases were screened and interpreted by 10 pathologists to evaluate and to make like an original thin prep diagnosis, initial diagnosis. Then the study design, 2 pathologists reviewed the 20 OOI, the area of interest of the whole 32,451 cases. Then a 3rd pathologist with the original 2 pathologists would review cases with discordance between the 2 pathologists on the AI site, discuss them together, and form a consensus called AI site pathologists. Then they did a comparison of the Bethesda scoring system between the original thin prep interpretation that is done by the 10 pathologists and the AI site pathologist interpretation. So the 2 pathologists performed similarly. This is like a graph showing how the 2 pathologists performed. The 2 pathologists performed similarly in the beginning with an initial average time of 65 seconds per case. However, after using the AI site system, their time to complete a case decreased. With that being said, there's no comparison that was made with another platform, another AI system, or with the cytotechnologist skills. So statistical analysis, they did like a multiple statistical analysis, and I choose to include a couple of them. For this one, they talk about the comparison of the Bethesda system reporting system rate in AI site between the 2 pathologists. So the comparison of the Bethesda reporting system rate between the 2 pathologists revealed overall good diagnostic concordance. The discordance was shown in 1,400 out of the 32 451 cases, which is like 4.31%, mainly in the category of ASCES, and the high discordance seen was in ASCES category between the two pathologists. The second table was the comparison of the Bethesda reporting system rate between the AI site pathologist and the original temp prep interpretation. The comparison between them, between the AI site pathologist and the OTPI for the 32.451 PUP cases showed significant differences in reporting rate, with the AI site pathologist interpreting more abnormal cases such as ASCES, LCL, and ASCH. None of the 127 HCL or the squamous cell carcinoma cases in the originally thin prep interpreted were interpreted as negative by the AI site pathologist. So AI site pathologist did not misinterpreted any of the HCL or squamous cell carcinoma. And the overall moderate diagnostic concordance with a kappa of 0.61 was noted, with a poor agreement for glandular cell lesions. Another table, also table 4, shows that PAP negative cases were mostly benign, while higher grade lesions like ASCH and HCL squamous cell carcinoma had high detection rate for CIN2+, which is 67.83% and 83.53%. And among atypical glandular cell AIS and the adenocarcinoma and the adenocarcinoma in situ cases, 66.67% were confirmed as adenocarcinoma with the histologic follow-up. The comparison of the sensitivity and specificity for the CIN1. Sensitivity for detecting CIN1 was similar between the OTPI and the AI site pathologist, but the AI site pathologist showed significantly higher specificity, positive predictive value, negative predictive value, and accuracy, with a notable improvement in negative predictive value. And then when it comes to the comparison of the sensitivity and specificity for detecting CIN2 lesions between the OTPI and the AI site pathologist, both had identical sensitivity of 97.89%. For diagnosing of CIN2+, but AI site pathologists showed significantly higher specificity, positive predictive value, negative predictive value, and accuracy. So what are the strengths and the limitations of this study? So the strengths, the AI site program significantly increased pathologist reading efficiency after familiarization, estimated at around 3,500 cases for optimal adaptation. Also, the AI site maintained a high level of diagnostic accuracy, with a kappa value indicating acceptable agreement between pathologists and the original interpretation. AI site offers higher sensitivity of 94.88% for CIN1 and CIN2. Both AI site and manual interpretation missed 6 cases with a 97.89% sensitivity. Also, the AI site showed significantly higher specificity, accuracy, and predictive values compared to the manual interpretation. The limitations or the area of improvement would be, so the study is retrospective design, lack of certain patient details with a specific OOI, which is the object of interest, that might give some kind of introduced bias. AI site software is difficult to replicate, and without purchasing it from the company Rohner, recreating the same program would be challenging. And the average reading time for AI site was 22.23 seconds per case, in contrast to an estimated manual reading time of 180 seconds using the original thin prep interpretation that was mentioned in the paper, but although the latter figure is not sourced from a reference, and the AI site also system is interpreting slides too quickly, like in a gold standard in cytology, which include limitation related to the OOI, with the area of interest. And that would be it. Thank you so much for that's for my journal club. Thank you.
Thank you very much for the presentation. Appreciate these three excellent presentations. And if we can have the presenters come back on video, we can perhaps field some questions. For Dr. Manrai, I do have a question about the study protocol. So your study discussed patients having both the self-collection and also having an appointment scheduled. Is that correct?
That's correct. Yeah.
You know, those who were positive on self-collect, they mostly went to colposcopy. For those who were negative on self-collection, do you know what happened at those appointments?
Yeah, so for those, and I can pull up, let me pull that up here. I'm going to share screen real quick.
Yes, go ahead.
Yeah, so for the ones that were negative, and then, yeah, 277, scheduling assistance was given for 269 of them, in terms of actually being able to get in touch with them, but then they don't have, whether they followed through or not, or came in, for testing. Yeah, unfortunately.
Do you think the intention was for them to have an in-office co-test?
I think so. I think that was the goal, especially because this was it wasn't a validated way to test for HPV. And so if they had used this as their method, then they would have been they would have missed their window for testing. So yeah, I think the goal was ultimately co-test is what they wanted for them.
Yeah. What do you think are the overall disadvantages of self-collection?
So one of the things that I think I have a hesitation with, is it really capturing it? I know that a lot of the studies out there are showing that it can, and it's comparable to clinician collected. The other is that, and this is devil's advocate, but that could it even create further inequity in that people who need to get these self-collection kits, they have to have a stable place to get, like an address even to have that kit. And they have to have a phone in their house. They have to be able to mail it back. They have to understand this whole process. Like, it's hard enough to get like a voter thing in the mail. So it's, I think that it might even cater to women who already have access to testing. And that's one of my worries, is that the intention is to reach people who might have an inability to come to appointments, but I wonder if it'll even widen that gap.
Thank you. For the audience, I'll mention the initial approval in the United States is going to be for in-office self-collection for patients who are not amenable to having a sample collected by the provider. It's assumed that the next step is at-home collection that would be subject to all of these downsides and issues. For Dr. Mahjabin, I wonder if you can help us to clarify a couple of things. One is that you discussed two different types of specimens, pelvic washings and ascites. Could you describe the differences between how those are collected, just to make sure that the audience has captured that information?
Okay, I'm gonna share my. So from the paper, my understanding is that the patient who had their they collected the specimen, whether it's the pelvic washing or if the patient is already have the ascitic fluid, they collected those cytology specimen at the time of the surgical resection. So this is my point of view, that if the patient had the ascitic fluid, it actually clinically it means that maybe the patient already has the disease which is spreading to the peritoneal fluid or the peritoneal metastasis, so the patient get the ascitic fluid. And the result, we can see that if it's the ascitic fluid, then definitely the cytological detection rate is much higher than when the patient get the the surgeon do the pelvic washing and then collect some pelvic washing fluid and then send it for the cytology. But both of type of the specimen they collected at the time of the surgical resection. So that's why I said that when I was saying that the areas of improvement that I think we need larger study to further investigate that actually the detection rate in the ascitic fluid is like more in or comparing to the pelvic wash specimen, because to my knowledge, like if it's the ascitic fluid, the patient already have it, then definitely it's already metastasis to the peritoneum. So definitely it will detect in the cytology specimen. That's why I think we need a larger study or further study to see the accuracy of this statement.
Thank you very much. I think that's very important information to specify. And you have also simultaneously answered a question in the Q&A box. Someone asked whether there was a difference in time to surgery between the negative and positive cytology specimens, and it sounds like all of these cytology specimens were dated from the date of surgical procedure. So there was no difference, zero days. They were not preoperative ascites specimens. So thank you very much. Dr. Ordulu, do you have any questions, by the way?
Yes, so I mean, we do have kind of an interesting articles, especially the ones about the new technologies that are coming into practice. Like when you think about between the self-screening and the AI methods, it sounds like these things eventually are going to affect our practice sometime soon, I assume. So maybe we can ask Hafsa about how rapidly do you think this is going to be in practice, and does she think that, you know, there's a question in the chat that they are asking if remote areas can use this tool for cancer screening when there's no pathologist or cytotechnologist, for example. Do you think it's coming close to being in real time, or do you think it still needs some work to do? And it's just a commentary, not necessarily, you don't have to have a right or wrong answer.
Yes, I think with what we are seeing with the digital pathology and all this AI, the advancement that we are seeing in pathology is going very fast. So I think it might happen very soon. But me personally, I still would like to have a pathologist to verify and make sure that everything is correct. Especially, like, for example, the paper that I presented on AI side, there's only like 20 objects of interest that are marked. So what about if we're missing something else outside of those 20 objects of interest? So it's a little bit scary to me when it comes to relying 100% on AI only. I think AI always need a pathologist. And pathologists can be available remotely, where they can check the whole slide image using the digital pathology. I can see that as a potential in the future of digital pathology and pathology. Yeah.
Yeah, I feel like if there's nothing else going on, maybe this could be helpful. But when it's possible, it's before we like, especially before we validate, right? You need to be careful to apply them immediately, I guess, is the main take. Whenever you have a new technology, you need to be careful. Yeah.
Great. Well, I want to thank our speakers again for presenting at Journal Club. These articles are available in the literature for you to read, and we're happy to help people gain access to them, point them towards them if you need a reminder of what the reference is. We have one more comment that there can be a lack of access to pathologists in certain regions, and that's not only an essential issue, but something that we hope to address through our society. So thank you all for joining, and we'll see you at the next ISGyP Live event. Have a good
Thank you.
afternoon.
Thank you.
Thank you all for coming.
Bye.